Hi, I'm Dr. Brian Gillis, and I'm going to give you a real-life example of anorectal functionality. This is one cheek, this is the other cheek, this is the internal sphincter, and this is the external sphincter, okay? And this is the rectum, and this section over here is the sigmoid colon. So we're going to describe a few things here. First of all, one thing that we want to know is what is the sphincter at rest, because that's important. We want it to be between 80 and 86. When we see it elevated, we call that hypertone. Hypertone can create issues with hemorrhoids because the tissue is engorged. Any muscle that's under a lot of tension can cause some venous engorgement, and venous engorgement, when it becomes inflamed and irritated, can lead to things like hemorrhoids. One of the other issues that we look at is an anal fissure. With anal fissure, we have hypertone and we have elevated resting pressures. So in this particular patient, we have an elevated resting pressure of 92. So we take a measurement and we have them squeeze as hard as they can, and then we take an average of that, and in this particular case, the person was able to squeeze to 106. We subtract those two numbers, and the number that we come up with is 13.4. We know that 15 is the squeeze strength that we want. So in this particular person, even though they have an elevated resting baseline, their external squeeze strength is low. That's significant because when the stool, because of a gastrocolonic reflex, goes to the rectum, the internal sphincter relaxes and you get the call to stool. The thing that allows you to make it to the bathroom is your external sphincter. You squeeze that together until it's time for a call to stool. So when somebody has a diminished squeeze strength, they can suffer from fecal urgency and fecal incontinence. So this demonstrates that this person has some muscle atrophy issues and has an elevated resting pressure, hypertone. The other thing that we look at is we look at what do they do when they feel like they need to bear down and have a bowel movement. This number jumps up to 106. It should actually be less than 92. We take a ratio of those two numbers and we want it to be less than 1. So this person has also what we call paradoxical contraction. And that means that the sphincter can prematurely close. You're straining against a closed sphincter, and you can end up with something called incomplete defecation. And incomplete defecation can be problematic in the sense that it can make you feel like you're not completely empty. You can have mushy, long, thin stools. And if the pH is elevated, as it is in this person, around 10, it's alkalinic. We like the pH of the stool to be around 7. So we want to do some things that focus on changing the stool caliber, viscosity, water density, and pH, and timing. So those will be imperative to correcting some of these anorectal functionality measurements that we've taken. The other thing that we look at is we look at the compliance within the rectum itself. And when that is abnormal, patients can have decreased rectal compliance. That can also lead to fecal urgency, and that's usually secondary to an alkalinic stool. So some of the simple things that you can do to improve an alkalinic stool is have some fiber in your diet, non-soluble as well as soluble, and that will help drive down the pH. Also in your diet, a low-fat diet, low-carb diet, low sugar will also help drive down the pH of the stool to have a happy, healthy bowel movement.